So good morning. Thanks for that introduction, Grant. So really, it's an honor to be here with all of you this morning on behalf of myself and Beryl D'Amato from UCSF. I'm going to be presenting the results from the OMF survey that was collected recently online. We had over 200 responses in less than a week, which is just really incredible in the amount of interest and feedback that we received. So I'm going to start off with a patient quote from the survey, and you're going to hear a number of quotes from patients throughout this talk because we really feel like it adds so much more depth to the findings than just the statistics we're going to be reporting on. I was abruptly told that I had cancer in my eye, that the treatment was to take the eye out, that the doctor had room in the surgery schedule for a week from Thursday, and that I was to stop by the receptionist to make an appointment, nothing more. So this quote really for us as physicians is a bit of a reality check. As far as we've come in terms of understanding ocular melanoma and advances in genetics and therapy options, really there's just a lot of room for improvement if this is still occurring. So for the survey, as you can see here in this map, respondents were from all over the country, East Coast, West Coast, Midwest. And if you see there, the orange dots are patients who received plaque brachytherapy. Blue dots are proton beam, red dots were enucleation. Really, we had a very wide range of respondents. Of those who responded, 180 were patients, 27 were caregivers. Of the patients, 2/3 who responded were female, 1/3 were male. And for caregivers, actually 3/4 were gentlemen and 1/4 were females. The median age for patients was 52. There was a pretty wide range from 24 up until 86. In terms of tumor location of the respondents, the vast majority were choroidal melanomas with some ciliary body and iris melanomas, and this is really in keeping with studies that have been published in the US and abroad. So getting down to satisfaction with tumor detection, 87% reported being satisfied, about 13% not as satisfied. So here are some quotes from patients. I wish the first 2 eye doctors I saw before the final one would have caught it earlier. I wish my optometrist had dilated my eyes regularly. He only does it in people over 50. My ophthalmologist should have listened to me when I kept telling him there was something wrong with my eye. Instead, he just kept telling me that nothing was wrong, that my eye was perfectly healthy, and that it was just stress. It was only when I was demanding to see a retinal specialist that my ocular melanoma was diagnosed. For satisfaction with tumor diagnosis, the vast majority were satisfied. A few other telling quotes here. One patient reported, I wish I'd been encouraged, given the risk, to treat the nevus when it was discovered rather than waiting 5 years and finding out it was a class 2 tumor. The doctors were always so worried about saving my vision. I wish they'd been more concerned about saving my life. Another patient reported, the main thing I wish that had been done differently was that the ophthalmologist who first photographed my nevus should have told me there was a chance, however small, that it could become a tumor, and that's why it should have been watched. Even though he told me to come back in a year, he basically told me there's nothing to worry about, so I didn't go back for 2 years. For satisfaction with treatment selection, 90% were satisfied. The first quote here is somewhat important. So this patient said, it seems each doctor pushes their own agenda. One only does plaque, one only does laser. Another patient, I wish I knew more about the various modalities of treatment and was given sufficient time to make decisions. A last patient here, I was not told of other options of treatment other than plaque, nor was I informed of genetic testing. Now, in terms of the tumor treatment of the patients in this survey, 76% received plaque, 9% proton beam, and 10% had enucleation surgery. A very small fraction had transpupillary thermotherapy or stereotactic radiotherapy. And again, this is in keeping with the availability of plaque brachytherapy and kind of practice patterns throughout the states. Other concerns that were raised were too little time between diagnosis and treatment to think about all the options, lack of counseling about the possible symptoms postoperatively, pain after enucleation. And the last quote there, a patient said, the doctor was great as far as getting the tumor, but very unconcerned with the other things that happened to the eye after the tumor was taken out. This is these statistics are actually very surprising to me as a physician that, 37.2% of respondents were actually not offered prognostic tumor biopsy. So a couple other quotes from patients that might illustrate why this is. The initial ophthalmologist did not recommend a biopsy. He said it could seed the tumor, and I felt his knowledge was not current. This was in 2012. Another patient, I wish I had been better informed about the biopsy. If I had known it was only a 1% risk, I would have gone somewhere to have the testing. These are the patients who included their gene expression profile result here, and they were asked if they were happy to have the information, unsure, or if they regretted it. Interestingly enough, only one patient of all the respondents who mentioned their class had regretted having that information. Two other patient quotes here. One patient, I felt pressured by the surgical team to not do a Castle test, and I wish it hadn't happened. Another patient, initially no genetic testing was offered or discussed. Testing was done 2 years after brachytherapy and showed 1A. 6 months later, metastasis occurred. These are some quotes that patients provided regarding compassion. And really, to me as a physician, it's heartbreaking to read these, but I think it is important to bring this just to, the attention of not just this group, but others in the medical community. So one patient reported, I had no clue that I was going to receive a devastating diagnosis. The doctor bluntly told me I had a huge ciliary body melanoma and sent me to the waiting room by myself to wait for a referral to the ocular oncologist. No kindness, no support, no concern for what that news meant to me. Another patient reported the diagnosis being communicated in a very clinical manner. Other patients reported some lack of sensitivity on the part of their physicians. Communication is key here. So these are, again, some patient quotes on communication between the doctor and them. So one patient reported, the doctor dictated notes over the phone in my presence prior to discussing the diagnosis with me directly. Another reported, at initial diagnosis, the ophthalmologist could have spent more than 5 minutes with me after announcing that I have cancer. I asked for a follow-up session, saying I would even pay for his time, that I just wanted to ask questions. He answered 3 questions, I had pages of them, and said, you will never be an ophthalmologist no matter how much you read. Either do as I say or leave. I left. Another patient, a non-specialist, just said, well, you have a tumor and I'm pretty confident that it's cancer. Another patient reported, doctors do not want to talk about dying or its possibility. They don't like to discuss things that they can't fix. I was not made to understand that it was cancer that we were talking about. The doctor later said he didn't want to scare me. And lastly, I was left only to arrive home without notes or materials and not remembering a single word the doctor had said. In terms of information provided, as you can see, under half of the respondents felt that adequate information was provided. So I think in terms of this page with quotes, the most shocking one to me was, we were told to search Google for further information. Another patient, after enucleation, my surgeon said twice you were cured. I wish I could believe that, but that's not what my research has led me to believe. Fortunately, in terms of emotional support from the physician, over 3/4 were satisfied. However, that number still isn't high enough. Some patient comments here. The doctor just wanted to focus on the eye with cancer and not the person with the cancer. The treatment of the disease was excellent. The treatment of the person how to deal with the cancer diagnosis could have been much better. And last, I wish my surgeon had prepared me for the post-surgical struggles I have experienced. These are the respondents, or the figures on the impact of melanoma on life and family. And again, just underscores the lack of information that patients are receiving. In terms of psychological support, just over half of patients were satisfied with the amount of support and counseling they were given. And again, we need this number to be much higher. Now, finance is an issue that is becoming more and more recognized to us providers. It's important to provide this information to patients. Quote from a patient here: "I'm still paying for an MRI that I had last summer that was over $5,000. My insurance only paid a fraction of that. I feel like there were so many things I wanted to do, places I wanted to visit, but there are expenses, even with insurance, that have made me so broke I'll never get to go there. I feel I'll spend the rest of my life working to pay for my cancer treatments." Having to deal with being screwed by insurance, even when you have it, is just as traumatic as the diagnosis. The fear and concern of leaving your family in financial ruin can be very stressful. Now, in terms of screening for metastasis, 88% were satisfied. There were some comments regarding the discrepancy in some of the screening protocols that are offered at different centers. So one patient reported the protocol after the plaque treatment was blood work every 6 months and an x-ray of the lungs every 12 months. I believe the metastasis to the liver could have been found earlier if CT was part of the protocol every 6 months. Another patient: "I wish the MDs talked more about ways to monitor the disease besides CT scans. For instance, doing MRIs, which expose to less radiation." Another patient: "The oncologist I was referred to for follow-up refused to schedule MRIs every 6 months. Only 6-month ultrasound, since it wouldn't matter when the mets were found." This is heartbreaking. Once you have metastasis, you're dead anyway. And lastly, my medical oncologist was clueless in ocular melanoma. Here are suggestions that were brought up by patients throughout the survey, which I think we need to look at very seriously. So, one patient suggested there needs to be an active network for patients to sign up for so that they're contacted regarding clinical trials that fit their profile. Others suggested preparation for the anxiety and adjustment period, and the encouragement of psychological counseling to help with acceptance of the disease, and someone just to listen to fears and concerns in the office. This is something we actually do at UCSF, but it's to provide each patient with a person to talk to that's already gone through the process. Follow-up phone calls after treatment, provision of better understanding of how the disease can impact a patient's career, and additionally, resources for helping to fight insurance when claims are denied. Better biopsies for future diagnostic testing, and lifestyle options, as well as brochures in the waiting rooms for Cure-OM and OMF. So these are just some of the things that Bertil D'Amato and I do at UCSF. It's interesting. So when Bertil came from England, he'd been in the practice of tape recording his conversations with patients for many years. I remember when he first came and mentioned this to our faculty, people were kind of a little uneasy about that idea in our current kind of medical legal climate, but it's something that he and I both do for all of our patients. So we actually audio record our counseling, and we have it emailed to the patient so they can refer to it later. It's nice because it allows the patient to kind of free up their hands, not have to take notes, just to really listen and focus on what we're trying to tell them. We also do send copies of our reports and our letters with photographs and images of their tumor and treatment. We're careful to discuss all treatment modalities, even ones that we don't offer at UCSF, and to offer second opinions elsewhere. Also, we do counsel patients extensively on prognostic biopsy with next-generation sequencing, cytology, and the Castle test, as well as other tests. We also inform them about the website that we've developed, and we certainly try to give news in a very sensitive manner. Now, something that we offer all of our patients is to see a health psychologist, actually. And we do stress to all patients what a health psychologist is, actually. So we tell patients, a psychiatrist is someone that patients see, patients with mental illness, whereas a health psychologist is someone who helps patients who are perfectly normal and healthy deal with stressful situations. And so this is a resource we've offered all of our patients who come through. And the majority have actually taken us up on this offer and have had really positive feedback in terms of helping with their coping skills and with everything else. We do have an ophthalmic nurse as well who calls after the first day after surgery and keeps in touch with the patient for questions later on as well. So I guess I want to leave things on a positive note. I think there's tremendous resources in OMF, and this group right in front of us right here. It's really impressive that we were able to rally so many patients to respond to this survey in such a short amount of time. And we're hoping to publish these findings really in the ophthalmology literature to bring to light what a need there is for patient-reported outcomes and how much room for improvement there is in terms of educating our patients and really offering all the resources possible. This last slide, this is something that Bertil brings up. This is actually on our website. This is a scope for a patient's bill of rights. I know it's something he's very passionate about, but this is something that we advocate and we give to all of our patients just so that they're aware of what to expect from the care that they receive with us. So thank you for your time and your attention. We've heard some really inspiring things throughout the meeting, and we'll certainly open the floor for questions.
Yeah, I've got a couple questions. Did you note any differences when you looked at the proton beam radiation, if that was primarily East Coast, West Coast, and not much in the middle of the country?
So you're correct. So certainly on the West Coast, there's a proton beam facility in San Francisco. I'm not sure if I can bring the map back up, but you'll see that on the West Coast, there were some patients in the Midwest, though, as well. And there is a facility at MD Anderson, from what I understand, so they may have gone to a more regional center. But it is true, there are more proton beam patients on the East Coast and the West Coast where the cyclotrons are located.
And my second question was, you mentioned that someone had gene testing done 2 years after therapy and was diagnosed class 1A. Is that typical that you can have that done 2 years after therapy?
Well, I think to answer that question, first off, none of the genetic testing methods are validated for after radiation. However, there is some data out of England. So Dr. D'Amato's group actually did do testing after radiotherapy for many years on many of their patients. And they didn't do it 2 years out. They did it very soon, within a month or so afterwards. And their group stands by their data to say that you can actually do testing after radiotherapy in the short term, meaning right afterwards, and they feel that this testing is still accurate. But the Castle gene expression profiling test for sure is not validated for after radiotherapy. And the company will tell you that as well. Great.
I gather from being here that a lot of you doctors all over the country share your information. Double question. Share your information, and I'm not sure if it's just statistical, but it sounds like from what I just posted up there that you offer a lot of information initially to patients receiving this diagnosis. My question is, well, I don't know if it's a question, it's a statement actually, because I'm treated on the East Coast, I'm treated in Philadelphia, and nothing, absolutely nothing was offered to me. And I don't understand why, across the country that, you have all these services for patients, and yet in Philadelphia, big city, why, you sit in a waiting room and get all this testing done and no services were offered, nothing.
Well, I think that's part of the reason that we're all here, and part of the reason for this survey was to just spread awareness of the fact that there's progress to be made. But I think what we can do certainly is, I think you have a wonderful forum here, just kind of spread the word about different resources that are available, different websites, that kind of thing. We can certainly gain some ground in that area.
To follow up on that question, how do you plan to disseminate the results of this survey? It's fine to tell us. We can't do anything about it. Are you brave enough to tell your colleagues and lay it on the line?
Absolutely. We're actually working on publishing this in an ophthalmology journal.
And taking it to conferences?
Absolutely, yeah. And Dr. D'Amato actually presented this in front of our entire department a few weeks ago at Grand Rounds to bring this issue to the attention of all the other faculty in our department as well.
Yeah. Because I think for a lot of us, seeing some of those, I don't know how many of you had your hearts just stopped because it was like reviewing past history. And you know, I liked the comment of, it's great to have someone who can treat the disease, but the person behind the disease is, a lot of us felt pretty fragile with some of that. It's like they missed Bedside 101 lecture.
Well, I think to answer your question, this is definitely an area of concern for us as well, and that's the reason why we've submitted for this PCORI grant with Dr. D'Amato, Dr. Shields, Dr. Singh, and others, and we're pretty optimistic that with some revisions we can hopefully have a good chance of getting funding for that. But that entire grant that they've mentioned it's about patient-centered outcomes and patient-reported outcome measures and really helping to improve the whole patient care experience. So I think the future looks bright, really.
I just wanted to kind of make a statement. I don't remember seeing this survey, and I don't remember responding to it. But I was one of these people that, you know how you go in to visit patients, you know, and you come in with the whole entourage, and doctor never told me what she found, and she stood there and dictated that she was going to do the plan of treatment was enucleation. And I sat there and I was completely devastated because we're all informed and we all know what that means. And I just thought that was just the most insensitive thing that I had ever heard. So it was horrible.
I had a nevus for years. My ophthalmologist saw it, photographed it every year on a dilated eye exam. Never recommended a retina specialist. Fortunately, I had my cataracts removed by a different ophthalmologist who immediately said, I see your nevus, I've looked at your prior records from your doctor, I think you need to be followed by a retina specialist. The retina specialist did sonograms because mine never changed in size from looking at it straight on, but it grew thicker. But for the sonogram, I don't think you can tell the difference. So I guess my question is, shouldn't ophthalmologists be taught that maybe just looking at it head on isn't enough to track, you know, a nevus as far as whether it changes? Because mine changed, as I understand it, strictly from a thickness standpoint and not a circumference or diameter standpoint.
I think you raise an excellent point. It's very common for us to see patients who've been followed for an extended period of time, then there's been a change. That being said, I guess the real problem is, and this is a theme that I think we hear over and over again, the incidence of this disease is about 5 to 6 patients per million per year. So if somebody's looking at it who maybe hasn't seen very many ocular melanomas, that might be the difficulty in really knowing that what they're looking at is high risk. It's not an excuse by any means, but it is not an uncommon scenario, unfortunately.
I just want to say thank you very much for doing the patient survey. I think it's critically important. I think a couple of things that are going on here, perhaps the possibility in the next conference is to be able to have an audience where, in a small group or whatever, where people can recount these experiences. I certainly had my own, and I don't need to go into them at this place. But I also want to help the audience have a perspective, perhaps, is that what you're doing is trying to turn the tide. And this is a very challenging time. We have a great opportunity because we do have online presence, and you're able to gather the information, but then you're taking it back, as I understood, to publish papers to be able to educate the professionals. Because I think none of us really need to have the experiences that many of us did have And in part, it's because we have people who are not educated about current literature, and that they're not, perhaps it's a personality issue, or perhaps it's the opportunity that, you know, we're becoming more compassionate and more aware. But I'm going to continue to encourage. My ophthalmologist at home is clueless and does not believe that it's appropriate to educate us about the online presence. He's not willing to do that. And so it's like we're fighting upstream.
Sir Adele?
I'm glad to see that result because I was Dr. Love's first person patient in the United States, and I was treated very well. But the upcoming September in 2013, I participated at the OMF conference, and I was part of a newly diagnosed group. There were 16 people in the group. Myself and maybe partially one other person were the only two that got correct information in a timely fashion and were treated as human beings. And the rest of the people, I was shocked to hear, especially the people that got all the way home and said they couldn't remember a word that the doctor had told them. So I'm really glad to see this documented, and I hope we continue to move forward with spreading the word to the practitioners. Thank you.
Thank you for that. It's inspiring how you guys are treating your patients. I just wanted to clarify that in regards to the post-radiation testing, Impact Genetics test has been mirrored from Dr. D'Amato's process in the UK. And although it is not validated, we do perform genetic testing post-radiation. We've had quite a few that we've got successful results. So while the validation process is in the process, it is an option in our test. Our first patient was 10 years post-diagnosis, so she had a recurrence.
So I do want to mirror that comment. So again, this is not validated, but we've done next-generation sequencing on patients after radiation as well at our institution, and we have had concordant results both before and after radiation on the same tumor, actually. Even. So this isn't published data, but it's an area of some controversy. I think the official party line is nobody will tell you that their test has been validated for after radiotherapy. However, there are cases when it's been done and it seems to be effective.
Yeah. So we do get that question, but we have done it successfully, and we use Dr. Copeland's same method, so.
I just wanted to say, my name is Melissa. I'm here with a friend of mine who had invited me a year ago to come to this conference. And as a medical provider myself, listening to these statistics and survey results is very heartbreaking. And just to mention to all of you here, I think historically, when you look across surveys across the United States, whether Press Ganey, I'm sure you must be familiar with them, they do a lot of surveys for hospitals and patient satisfaction, that this is not the only area where we suffer in communication to patients. And what's really sad is that when you look at it on a whole, the patient is not given the time with their provider to sit there and really learn. The other aspect is that the provider was never taught that either. So it's definitely a learning curve. However, it's very sad because the provider that knows the information, it reflects in the survey that the patient themselves are not comfortable with their conversation with their physician or the provider. And it's quite sad. Hopefully, through some of these surveys, that instead of bringing it to patients' attentions or to the staff, that it is more, and not so much publishing, but brought out into hospital settings and office settings where common people can see it, instead of scientific magazines and journals where people don't understand the data. And it's quite unfortunate, really, when you're given a diagnosis or a prognosis of something and you're not fully aware of the understanding and leave feeling you know nothing. So it's very sad.
So I wholeheartedly agree. I think part of the issue too is as an ophthalmologist, so ophthalmologists are trained really in treatment of the eye, in eye surgeries, and the vast majority of conditions that are treated are not life-threatening, actually. it's
Well,
cataracts,
I think
glaucoma.
to answer that, even though ophthalmology, it's in any profession across the board, the fact is that nobody's really taught bedside manner.
Oh, I wholeheartedly, I
And
absolutely agree with you.
that's the thing, people are looking for compassion.
Absolutely. So what I was saying is we're trying to bring awareness to the fact that in ocular oncology, really we want to emphasize a more holistic approach that is seen in some of the other fields like internal medicine and
But they
systemic
don't,
oncology
but
that
you're taught
includes.
that. You're not, you know what I mean? If you're not taught that, it's hard to communicate that.
Correct. But that's the message that we're trying to push forth, is that we really need a more holistic approach, not just to treat the eye or the cancer,
Right,
but
the
to
whole
treat the whole
person.
body, the person.
Yeah.
I just wanted to tag on a comment to Jamie's comment about post-radiation treatment or testing for proton beam and plaque patients. I think I was the first person to go public on the support page because Dr. D'Amato was one of the only doctors in the United States willing to do a post-treatment biopsy. And we didn't get enough tissue at the time of treatment to do Castle and second-generation testing. And Bertel said he was willing to do post-radiation biopsy because it's the norm in the UK and Europe. And so I went in 2 months after treatment and had the second-generation testing. And I got a lot of blowback from the community because they said, you're not getting proper biopsy cells. And Dr. D'Amato said, we're getting dead radiated cells, we're getting dying radiated cells, and we're getting viable cells in that short window. Thank you.
Right, with the comment on post-radiation biopsy, again, as was alluded to before, I mean, currently none of the tests are validated for post-radiation, so they'll never kind of stand by the results afterwards. But I think in the near future, there'll be some published studies on post-radiation biopsies that will shed more light and maybe make it more acceptable and less controversial.
Just a quick aside, I think I worked in the medical field as well. I think historically, surgeons were never taught bedside manner. They were never, ever taught how to talk to people. And hopefully that's going to change. I mean, that's what happened to me. And I'm sure I'm not the only one. So they need to learn how to communicate with the patients and the families. It's not just the patients. I mean, I brought him with me to every visit because, like somebody over there said, I walked out of there not really listening, not hearing what was being said. But I wasn't given a whole lot of information because, and I know you guys have a lot of information up here, but you need to communicate it to the general public. So that's it.
One last question.
Dr. Afshar's study indicates and documents that a crisis is going on in the medical community. Patients' main complaint is they don't have enough time with their doctor. Doctors' main complaint is that they don't have enough time to spend with patients. In the dark ages, when I was practicing medicine, I could see patients, and I had secretaries who knew the patients, knew me, scheduled on time. After I retired from the medical community, the same University Medical Hospital where I was working now, by mandate from above, schedules every patient's appointment 15 minutes. During that 15 minutes, now with the electronic communications, the doctor is supposed to see a patient and decide what to do with the patient and has to spend part of the time on a keyboard writing the notes. It's an impossible situation, I think, and a very difficult situation for both doctors and patients. And I have to think that the crisis will come to a head at some point and there will be some resolution. But in the meantime, I think you document what is that patients just don't have enough time to have their questions answered by physicians, and it cannot continue.